night, everyone. Welcome to the Fireside AO series on tibial shaft fractures. I'm Tom Large, and I've got a great group with me tonight here. We have Milton Little from Cedars-Sinai in Los Angeles, and Mitch Bernstein from Montreal, Canada. We have no disclosures. All have been mitigated prior to this event. Our learning objectives for tonight are going to really focus on the distal tibia fracture. At the end of this session, we hope that you'll be able to identify the challenges treating distal tibia fractures, be able to describe various fracture reduction adjuncts, including when and how to do percutaneous and/or open reduction techniques, and to be able to outline pearls to intramedullary nailing of distal tibia fractures, including suprapatellar techniques, fractures involving the ankle, and extremely distal fractures. So the proximal tibia, of course, is like the youngest child. It gets all the attention, lots of papers and discussion on this kind of classic deformity pattern that we try to avoid with the proximal tibia of valgus and procurvatum or apex anterior angulation, and how we can use different percutaneous techniques, locking screws, and ultimately sometimes adjunctive plating to avoid these problems. But the same concepts may apply to certain distal tibia fractures and haven't been receiving nearly the attention that they might deserve. So this is a case of mine. This is a 23-year-old motorcycle accident from 5 or 6 years ago. This is an open fracture with a 6-centimeter wound. He had debridement of his wound and open clamping of the fracture through the wound, and a antegrade nailing technique, struggling with some alignment. The fibula was also nailed, but you can see still in some valgus malalignment at the end of the case. So we're going to kind of hopefully teach everyone tonight how to avoid this problem, and kind of discuss what went wrong and what we can do better to avoid this problem. In this case, about 7 degrees of valgus. This young patient may cause him some ankle and foot problems. So Mitch is going to get us started on how to get the distal tibia fracture right. Mitch.
Thank you very much, Tom. And thank you for sharing that case. You have to stop sharing / it's amateur night. Let me share my disgusting.
Stealing my lines.
How about this one? Can you see my slides? How's that one? That's classic.
Those look wonderful.
Okay, so hello. One of the disclosures is, and I'm not trying to be obnoxious, is I do take the goals of fracture surgery seriously. And I saw some of Milton's cases, and Milton's going to highlight a lot of these concepts as it relates to stability. I'm going to talk about stability, but also alignment and all the components of alignment. I'm going to go over some cases that had open reduction and IM nailing, but I do perform closed nailing. So I don't want you guys to think I'm totally crazy, but Tom showed a case, and I'm going to show you this case was performed at my institution here in Montreal. And like Tom said, what we're trying to avoid in this case for distal third tibia is malrotation and coronal malalignment. So here's a patient. He was 33. He has a AO simple spiral or shoulder oblique fracture of the distal tibia. It's extra-articular, and the surgeon chooses to indicate the patient for an IM nail. So here's the nail, here's the fluoro shot, and maybe Milton, you can comment on what do you look at? Like, how would you critique this fluoro shot, and what's the point of this fluoro shot for, at the end of the case?
I'm unmuting myself. I think the things that you want to look for on your fluoro shots, at the end of the case are what your overall alignment. It's going to be difficult to see right on a fluoro shot when you're looking at a tibial shaft fracture. So oftentimes, in addition to this fluoro shot, I'll get a plain film just to confirm that I am seeing what I like, seeing my overall alignment, making sure I'm not in varus or valgus. I also want to evaluate my reduction. As you said, this was a simple fracture. Was this a fracture where this was clamped in order to get reduction?
No,
Or-
I mean, but don't you? I find it's like almost you're not allowed to, or it's cool not to open reduce fractures when you do an IM nail. Like, what do you think about that comment? Like, do people make fun of you if you open reduce a diaphyseal or juxta-articular, extra-articular fracture?
I think there's a level of taboo to it because of this concept that you want to maintain the fracture hematoma in the area. You want to maintain the biology, and that anytime you open something, you are committing an assault on that biology. And I think that that taboo comes from not understanding that just because you open something doesn't mean you can't be very careful, very thoughtful, and maintain the biology in that same setting while still opening to do a reduction.
So this is the case, okay? So this is the case. He was then referred on to me. It's a young guy. He presented with like a flat foot because he had so much hindfoot valgus that he's like, why is my foot in so much valgus and so much rotation? So he had a closed nailing. It ended up healing, but you can even see the callus not forming as well on the tension side of this fracture because it was in valgus.
Mitch,
But yeah.
I don't mean this. I guess that was one thing that I was going to say in terms of when I looked at that fluoro shot, I want to look for where is my nail in the distal tibia. And you'll comment on this, but where is my, in relation to the plafond, right? To the center of the plafond, where is my nail?
So we will talk about that. So do you seriously look at that, Tom? Do you focus on the nail target? We're going to talk about that, but do you guys do that?
Yeah, I think the nail target's huge, and I think if you could comment on just this kind of standard AP view versus using a mortise view of what you think shows these deformities the best. What's the most accurate way to look at that while you're picking your distal nail target and potentially measuring malalignment in a case like this?
Well, I think if you're doing infrapatellar nailing, or if you're doing any nailing where you're flexing and extending the knee, where the AP of the ankle is hard to do, and if it's a closed reduction, you're always very anxious. You're so irritated by the fluoro swinging around for the AP, and it's a closed reduction, so you're just like snapping that AP and you're leaving it go, because to get an AP or a mortise, you got to internally rotate. And you're like, you don't have time to do that, right? So these are very easily, without an internally rotated proper mortise, I find it's very easy to sort of not realize you're way too medial on your distal nail target. But yeah, Tom, I mean, an AP or a mortise of the ankle with a beam centered on the ankle with as much exposure of the tibia would be good for evaluating deformity.
Yeah.
Hey, Mitch.
Super patellar nailing for these, both of you. Is that your preference whenever possible?
I actually don't use the super patellar nail. I'm a lateral parapatellar nailer. So Dean Lorich, a lot of the just like the Wash U guys, so Gardner and McAndrews. So I use a small lateral parapatellar approach and go extra articular, but still do semi-extended nailing because I don't want to deal with the flexion extension issues. So it has the benefits of avoiding intra-articular kind of pressures because you're staying out of the joint. You're not having to deal with the cannulas. I use an awl for my start point rather than a wire and an opening reamer. So I have a little bit more control of my start point. And then I can pass my wire, and then I don't have to deal with that flexion, extension, and movement And so I'm doing it all supine, and my imaging is pretty straightforward.
So great point. Just to clarify for the audience, I think sometimes those terms get lumped together. So semi-extended is the leg or the knee position, usually 10, 15 degrees of flexion, and then the suprapatellar versus lateral parapatellar versus some sort of parapatellar arthrotomy of some kind is just the approach to the nail starting point itself. So semi-extended position definitely helps with imaging and more accurate imaging, like Dr. Bernstein was saying.
And maintaining reductions, right? Because you're not,
Oh, yeah.
when I can hold and I'm just moving the machine, I don't have to move the leg, when doing that.
One question, how much valgus do I accept, or does one accept? I think those are good questions. I really don't know the answer to that. I mean, there's all kinds of literature on what is, quote, acceptable. I find them a little bit not nice to the patient.
I was going to say nihilistic.
Yeah, I mean, it's very judgy. Like, I don't know. I mean, I don't know. I don't know. Obviously, within 5 degrees is reasonable, but is it 4 degrees of valgus and 10 degrees of external rotation, and the patient's really into their leg, so to speak, and they're like, patients want to get back to what they were before. It's not, I don't think less of them if they want that.
As good as you can get it.
Yeah, as good as you can get it.
That's my goal is anatomic. And I think the other question they asked was, apropos to what you had mentioned before about looking at the mortise and the AP to evaluate the position of the nail. I think that is something very critical. You're going to get to that later, or we want to talk about that now, Mitch?
We'll bring it up in this case. So this is a young male who fell in the winter just at the beginning of COVID, and he had this distal third fracture of the tibia. That's his ankle CT. He had a hairline crack here, which I think the newer studies show like upwards of 95% have some sort of posterior malleolus lesion, whether it's this, I didn't do anything for it, but it's like basically always there. Here's that. Okay, so here's CT with 3D model. Looks pretty cute.
Mm-hmm.
Very juicy spike.
It is, but it's I think it's a very juicy spike, but it's also it can be, you can underestimate what that butterfly is going to do to you because of how long that spike is and how much that spike may slide.
So I went right to this slide because that's sort of what happens to me now in the OR in terms of how much I tolerate a close reduction of this. I get right to it. How much, so with this specific fracture, distal third, young patient, good soft tissues, how much do you tolerate a closed reduction? Same fracture pattern, clampable fractures. Like, what are you guys doing? Like, are you critiquing me here? Is this like, am I like a snob for trying to achieve this? Like, what do you think?
I would say I can't remember ever not clamping that in the last 10 years.
I've clamped
just
them
trying
all.
to hold it with your hands like you showed in the first case. I don't typically do that.
Yeah. I think that I agree. I'm also clamping this, and someone mentions using an AO distractor for this case. And I think the distractor is a great tool for bringing things out to length, and it is very helpful, but I still utilize some augmentation with clamping, even if I'm using the distractor, because it's a long lever arm. So you're still going to have sagittal plane deformity. You'll still have coronal plane deformity, despite having the distractor on.
Now,
yeah.
Mitch, I think the difference between what you're saying and what we're saying is maybe open versus percutaneous clamping. So you're going straight to opening this almost always, or do you like the proximal tibia? You know, it's will struggle for a while with percutaneous techniques and blocking screw, and then ultimately break down and open it and put a plate on it. Are you following the same kind of sequence, or are you going straight to opening this?
I stopped doing the percutaneous clamps because technically I futz around with it and I don't have the right clamp excursion. Either it's a large Weber, which is nice, but it's almost too big and they slide, or then I use a medium like this one, but it's too small. So you're doing the case and it's like, there's like, you know, an indentation. So this is a full, so this is a full blown open. So I do, and I didn't show pictures tonight, but like, I always look at the wounds on these patients. They are the most beautiful wounds. It's a long, like I don't do mini, I do a long incision, lateral to the tibial crest. I stay out of the anterior compartment, and then I come back to the tibia. I just touch the periosteum at the fracture site. That's all. That's all I do. Clean it, take suction, take the hematoma out and clamp it. That's all I do, guys.
And you have a big enough longitudinal exposure to get both tines of your clamp through that
inside
exposure.
yeah
It's not one
inside
tine through the wound and one through a separate prick incision.
No, they're both in the wound. They're both in the wound. Yeah.
I think that's the benefit of using that. Is that a medium? That's a medium pointed, right?
That's a medium. That's a medium. So you got to either have those peel pack, or, you know, they're not so easy to find, these mediums. They usually give you the wrong clamp. And then of course, if you look here, I would never assess my nail target on this. This is more of like an AP of the tibia of that fracture margin, but I would never use that to look at the nail target. So, you know,
real quick, how about you, Melton? Are you opening this? Are you still percutaneously clamping most of them?
I'm still percutaneously clamping most of them.
Any tips and tricks to avoid that skin crush with clamp selection or other ways to avoid that?
I find I get my start point. So I make my, I do my lateral kind of extra articular parapatellar approach, find my start point. I send my nail all the way down. I mean, my guide wire all the way down to just above the fracture. Then I put my clamps on and get my reduction. Then I put my, because, time is money. And so the more time the clamp is on, the more time, you're dealing with kind of the skin. And then the other thing for my geriatric patients and even some of my younger patients, I usually just poke hole or poke the clamp through rather than making an incision. Just because if there's any toggle in motion, it can cause those, like even a small little knife incision will extend proximally and distally. But if I just poke through, I get a little bit less of skin irritation.
I like to do a mostly perc with kind of a short anterolateral incision like Mitch has described, and walk the lateral tine down so it's outside of the compartment. It just walks down the tibia, and usually that's more posterior. And then kind of look at where the medial tine's gonna hit. And as Mitch was mentioning, there's different companies make different size and style of clamps. You can also add a screw on the medial side, to put the clamp tine in the screw to kind of offset it. I do think it's important to watch that you, especially in a sensitive skin patient, that you aren't causing any soft tissue damage with the perc clamping.
But yeah, I think that was one of the, as I've gone through practice, as soon as we hop in the case, the residents are like, well, grab the clamps, and they're grabbing the leg and they're trying to put clamps on. And I'm like, stop, let's get our start point. Let's move through this. and then, you know, get to this point so we're not having a lot of time with the clamps on.
I mean, that point is also the whole point of this, which is you have a distal to the isthmus fracture. So you could do, I mean, it's very smart what you're doing. You know, this reaming and preparation of the bone is independent of what happens here. And that's good and bad. You're taking advantage of it because, you know, whether I clamp it now or later, it doesn't matter, because that nail coming down is not going to guarantee anything down here. It's going to guarantee nothing down there.
Carry on, Dr. Bernstein.
Well, then I just put the guide wire in at this point. So, you know, if this, I don't remember. I'm pretty sure I did infrapatellar nailing for this, and I usually put the clamp on, and sometimes the residents get a little nervous. I flex, extend, flex, extend, flex, extend, and, you know, and I want to make sure it's stable, and then I move on. Next step, I am nailing. So here's just the, you know, the distal nail target. Here's the IM nail. Appears to be a little bit lateral. It's not a very good AP of the ankle. And that's what it looks like at the end of the case. That's an AP, well, that's a mortise. And then I always do for distal thirds, especially if there's a fibula fracture, I'll follow it up with an external rotation stress, like a real pull to make sure there's no ankle syndesmotic injury.
I think
Follow up.
I would go back to that. You know, I think that we're underselling how important your wire and your wire positioning is for these distal third injuries. And I think that, you know, getting the clamp right, getting it clamped, but, you know, that's not always the case. You don't always have those nice spikes. And when you get those ones, you know, that wire being right where you put it, Mitch, right in the center of the mortise, or if anything, just a titch lateral is where we want to be, right? That's going to be home for us.
And we'll talk about that also. But the other thing that's very confusing is sometimes it's easier to take the talus as a center as opposed to the plafond, because if you look at the plafond, you almost think the center of the plafond is here, depending on the rotation of the ankle. And that always, can you say screws me up on this fireside?
It's legal.
Okay, so that's why we almost are saying it's slightly lateral, but, you know, we'll go over in the journal club. It's not, it should be centered
on the talus.
Yeah, as defined by some of Paley's parameters in his book. And then we're talking about alignment.
Look at the talus on the mortise.
Yeah.
Talus on the mortise.
Just a final thing about alignment. Theoretically, if you want to check a coronal alignment of the ankle, you need the beam centered at the ankle. So these are tibia x-rays. The beam is obviously centered here, and it's oblique at the joints. So if you guys, you know, have post-op x-rays of a tibial plateau with a tibia x-ray, the plateau looks like complete garbage, or in French, poubelle. So same with the distal tibia. A lot of times it looks really much worse is because you have an oblique view of the ankle. So he never came back, this guy. He's like, I don't have any other x-rays on him.
PRN follow-up, he was so pleased.
I'm going to move on
to Milton's point for a minute. If you recall my case, open, clamped, you know, looked very good, and then the malalignment was, you know, like, okay, we're going to put the nail in now, and not paying attention to that distal nail target that I think resulted in the valgus malalignment of that case. Just to kind of hammer that home again.
I think someone here mentioned just bending the wire tip. Yep, that's a very, you know, that's something that helps you to guide your wire to where you want it to be. And then we'll talk about it in some of my cases, some tools that I use after we bend the wire tip so that we can make sure we're still getting the most out of that wire.
Okay, I'm going to show this last case. So here's another little bit more higher energy, a little bit more comminution. Is this amenable to an IM nail? Of course it is, hence the fireside. And you know, how do you do this properly? Now, Milton's going to show some amazing cases in a couple of minutes. So this is like just a teaser for that, but this is still quite challenging, at least in my hands. How do you do this? How do you do this properly if you're going to choose an IM nail? So here's the articular involvement or lack thereof in this case. You don't really have anything in the joint. Again, I'm trying to do closed nailing here, okay? So I'm just marking the fracture site at the beginning, and I'm going to, I bend the wires too. So in this case, I'm doing a closed IM nailing. So I want to make sure I can snake the guide wire into the appropriate view. And again, this is not an AP, this is not a mortise of the ankle. It's an AP of the ankle. So just keep that in mind, especially if it's a little bit even more rotated. You're not going to get a good view because you're going to see this line and you may push your wire all the way here. So that's my hand. I'm trying to do a close reduction, and I'll just ask you quickly, Milton, at this point, are you going for it? You know, like you said, the whole proximal tibia is prepared. Are you going for it with a closed, or are you going to secure the fracture before continuing?
Looking, you know, the amount of comminution there, this one, I think I'm thinking about how am I going to help myself for this case. And I don't think I'm going to get enough with hand pressure, or at least I don't feel I'm not good enough with hand pressure for these. So I'm looking at what can I do to help myself. And I think that fibula fracture may be something that may be able to help me a little bit in terms of reestablishing my lateral column. So I probably would be thinking about that to reestablish my lateral column. And if I do that, then I can think about sometimes putting it on a medial distractor to kind of help me dial in the rest of my reduction.
So are you making that decision pre-op? Like in this case, would you would have indicated the patient for an ORIF of the fibula first?
Yes, sir.
Okay. Okay. Well, I was a little anxious here, so I did an open reduction. And again, I'm not chasing, you know, I'm not spending these take, and I'm not for how quickly this takes very little time. And I'm not chasing comminution. I'm looking for a clampable fracture that will connect the proximal and distal piece and establish all the components of alignment. And then I'll just secure that nail target, which is so critical. Basically, the theme of tonight is so critical to secure that nail target before you ream or until the nail is in. So he actually had, and the other thing is, this is not uncommon, he actually had a little bit more fracture line comminution that went further down, wasn't displaced. Mm-hmm. So in that same incision, I just put an anterior plate, just a little bit of a increased stability, because I only have three interlocks distally, but a lot of comminution. And again, the AP and then the external rotation stress, because I did not fix the fibula. And if I'm not fixing the fibula, I really make sure the ankle's stable.
So you've just added absolute stability to a malreduced gapped fracture, Dr. Bernstein. Defend yourself.
So you're right. Okay. What I'm trying to do here is on fracture lines, and this is what I think. You know, it's not like I'm a god of fractures by any means. On a closed, shut down fracture line, in this case, the medial column and anteriorly, which was a simple read that was clamped, compressed, and anatomic, I'm just increasing the stability on that side. And the other side that was not opened or touched, in this case, lateral and posteriorly, will heal by secondary intention, by callus. And that's the strategy here.
You, Mitch,
so to be clear, I think on the lateral view, one could think that you are trying to lag
pull
that
in. No. I'm not pulling in.
Butterfly wedge back in.
No, it is
that wedge
not.
is posterior lateral, and you can see
Yeah.
on your AP, just like you're saying, your screws are all medial, and that is still a free, indirectly reduced fracture fragment amenable to micromotion
Right.
and secondary
Right.
healing.
And Milton, you'll see his cases in 30 seconds. I'm leaning a little bit not fixing the fibula, or at least initially. So this also helps increase the stability a little bit. But if I had the fibula fixed, I think that would be potentially better, quote, better.
So there's some data there that, fixing the fibula on this increases non-union rates, which makes some mechanical sense, that you're creating a stiffer construct on the, around the metaphyseal fracture when you're trying to get, secondary bone healing. Do you guys believe in that? Just to try to maybe quickly answer a field question.
No, I don't believe in it. I don't believe in it. What I do believe in is the sprint trial, and in my experience, if there's a fracture gap of a diaphyseal tibia, the non-union rates go up. So that's what I believe in.
Yeah. And I think your point is awesome, not just for the distal tibia, but a lot of other places, what's acceptable. If you go back to your kind of closed reduction attempt, x-rays, put a nail down in that position, and it very well might heal and do fine. But, to spend an extra 5 or 10 minutes to, open it or percutaneously clamp it and get it into a better anatomic position, I think is a 5 or 10 minutes well spent.
Mm-hmm. I agree.
To answer, we're going to go over another kind of classic distal tibial case here, but weight bearing status on these cases, with or without a posterior malleolus, Dr. Milton.
Distal, as I get to distal thirds, kind of more right before metaphyseal diaphyseal junction, right there, I usually will let them weight bear as tolerated. As I get to distal fourths, without a posterior, with a posterior malleolus, I hold them for 6 weeks. I make them toe touch with a posterior malleolus.
Mm-hmm.
Distal fourths, I tend to hold them until 6 weeks. So as they, some of the cases that I'll show, those I hold for 6 weeks.
Mitch? Younger patients, good bone quality. If there's good bone contact, sort of partial weight bearing. I'm sort of vague with the patient on purpose to let them weight bear a little bit. 6 weeks and then weight bearing at 6 weeks. If it's very unstable, then I'll put them in like a splint and even like a sort of boot for 6 weeks, and then at 6 weeks weight bearing. Like the first case I showed where it was clamped, and that guy was weight bearing at the beginning.
Got it. So probably around 6 weeks of some kind of limited weight bearing for the majority of these injuries, plus or minus a posterior malleolus, and maybe a little bit more conservative on a, say, elderly diabetic renal dialysis patient or something like that, where you really have really poor bone quality. Is that fair?
Yes.
All right.
But I think, that's my big advantage. Yeah, we'll talk about it.
I'm just trying to keep up with the questions. One, I'll just send this, but I'll answer it live too. Indications for fixing the fibula. I think, is this a ankle fracture variant? Is it a tibia fracture that's really an ankle with an associated fibula? And I have to prove that. So that's where the external rotation stress view comes in. Or is it, Milton's going to show, is it more a stability thing where you're going to fix the fibula because you need that augment, that lateral column augment for your fibula, or if I am nail strategy. So it depends. Is it a stability augment issue, or is it, an ankle injury? I think those are two things to separate.
Anything to add to that, Milton?
No, those are my same indications. I probably am, one question that was asked was about wiring the fibula. And, I think there are very great fibulas that are perfect for a titanium elastic nail, similar to the one that you showed in the first one. Those are length stable injuries though. Anything that's a long oblique fibula fracture, or even some of those shorter oblique fibula fractures, I think they may not work as well. If you go to the one that Mitch had on his was a little bit more oblique, so I think that wiring that fibula may not have given you what help you would have wanted.
Yeah. So to kind of summarize those points, several questions about fixing the fibula. So alignment aids, if you're struggling with your tibial reduction, fixing the fibula can be helpful to get length rotation alignment. And then from a stability standpoint, if you have a patient with poor bone quality, adding fixation to the fibula can be helpful. And then when the ankle is involved in a clear case, like I would argue this one, then that would be the other indication to fix the fibula. This also goes into another question raised by the audience. So about getting a CT scan of these injuries. I would say if it's possible at your institution and doesn't delay care extraordinarily, I think getting a CT in pretty much all of these cases is useful to be able to delineate the posterior malleolar injury and get a good vector on your interfragmentary screw for the posterior malleolus, because that's not always easier to be sure of on usually poor quality injury films from the emergency department. So this would be kind of a classic distal third fracture. As we talked about, almost all of these have a posterior malleolar fracture. You can see that on the CT scan, also an associated accommodated distal fibula fracture. So I think this would be kind of a classic sequence to get interfragmentary fixation of the posterior malleolar fracture, and then an open or percutaneous clamping of the long spiral tibia fracture. Again, you could fix the fibula in certain patterns where fixing the fibula first is going to help you with the tibia. But in this pattern, I think usually going after the tibia next is what I would do more commonly, and then nailing the tibia, and then fixing the fibula, and then doing a stress view of the ankle at the conclusion of the case. Dr. Milton is now going to take us from there into some even more challenging distal tibia fractures. Dr. Little.
There should be a disclaimer before he shows his cases. Do not try this at home. Someone just asked, what's too distal? I wrote ask Milton. Okay.
Here we go. Is there such a thing?
And nope. All right, go ahead. Can you come off, and I'm going to start sharing?
Once again.
Amateur hour.
Stop sharing, amateur hour.
Okay. We're at the second to last fireside. It's okay.
There's one more opportunity.
Let me move this board, and I'll set this up. Everybody seeing my slides? Yes?
Looks
yes.
Good, looks good.
Perfect. All right. Here we go. So here we have a patient, and we ask, this is why I'm talking about distal fourth or distal fifth tibia fractures. And, I think there's a lot of questions, and when I have certain subsets of my patients who you may be worried about other aspects, such as making big incisions and things like that. And so this was a 54-year-old HIV positive man who was struck by a motor vehicle. He's not homeless, but he is a little bit marginally housed. He he has a place to stay. He has family he stays with. And so, he can make it to appointments, but it's not always very consistent. So he was seen in an outside hospital and actually showed up to us about a week and a half later after undergoing this external fixator. His skin was actually pretty clean. And so seeing this injury, this is kind of the ones that I always want to get a CAT scan to take a look and see whether there is true ankle involvement. So here's our CAT scan. There's multiple images up top. You know, there was just a little small incomplete fracture, but no posterior mal involved. And this is all extra articular. And so when I look at this CT scan, the first thing I do on my CT scans when I see an injury like this is I will use my measurement on my PACS, and I would locate the physeal scar, and then I'll measure on my coronal and sagittal views how proximal or how distal the most distal fracture line is, because that gives me some information, right? I have to use whatever information I have in terms of possible implant choices to tell me, you know, is there an implant choice where I'm going to get a sufficient number of interlock screws? And for me, I think that's about 3 for these distal third injuries, because it's metaphyseal bone. You know, it's not like that, you know, it's not very sturdy bone. You're not going to get monster bite with your bolts, your interlocking bolts. So, you know, I really want to make sure that I'm going to get sufficient number of bolts to stabilize this injury. And so here's our 3D recon, and you can also see that he has this long spike that's posterior medial, which extends, as well as a very comminuted fibula fracture. So looking at this injury, you know, I had a lot of thought about it. He's already externally fixed. He has, you know, his skin is actually not bad. So with that information, I think Mitch and Tom, anything, you know, questions, comments, thoughts?
Well, the question for you is, there's a diaphyseal component to this, which when I see a proximal tibia fracture, I think they talked about it in the tibial shaft fireside, but when there's a proximal tibia fracture that has meta or diaphyseal extension, I have to make a decision. Is this a diaphyseal injury or a metaphyseal injury? Mm-hmm. So my question for you is, are you now saying this is really a diaphyseal injury in this particular patient, and I need something durable, hence I'm doing an IM nail, that's what I'm doing, and I'll worry about the comminution at the metaphyseal area? Is that what you're thinking? Like,
I'm thinking this is a metaphyseal, this is a really distal metaphyseal injury. And then my next thought goes, that diaphyseal component changes the working length that I would need with any type of plating I would consider for this injury. And then I say to myself, when am I going to let this gentleman walk? Or more
12 weeks of plating.
Or more importantly, when is this gentleman going to make himself or let himself walk? And so that's where my thought process goes. And so
how many points of fixation with a nail when you're doing your planning do you think you need in this location? Is 2 enough? Do you need 3? How do you make that call?
I want 3. I really, and generally, I want 3. You know, if I have a fracture, if I have all the fractures that you guys showed, those kind of, not all of them, but the ones that were just a touch higher, those distal kind of half, distal third, you know, those in a person with good bone, I think I feel comfortable with 2 good interlock screws. Once I get down here, once I get below, you know, once I'm at metadiaphyseal junction or the lower half of that portion, then I want 3 screws. And if I can't get 3 screws, then I'm thinking about this may be a situation where I may need to augment it.
And when you're kind of counting points of fixation, if you go back to your CT, I think, you know, if you're putting in standard screws, you might show us some different ways of doing this, but you're really getting kind of a unicortical purchase with probably 2 of those 3 screws, where one side's going into the fracture and then you're getting into that intact distal bone on the far side.
Exactly.
Does that change your thinking? Or
it does. It changes my thinking, and as I've been in practice, it's added another little tool that I think works pretty well it can actually accomplish a lot of things. It's a very simple tool. It's something we all have access to, and it's something that helps to restore that near cortex where I'm inserting. So, and that tool is a washer, right? So if you look in the 6573 cannulated screw set, or anywhere that has a titanium kind of large bore cannulated screw, those washers fit perfectly for interlock screws. And so that's almost like a way of restoring some cortex. And I'll kind of show that.
Awesome.
So, those are all the thoughts I have. And, I think like Mitch said, 12 weeks, this person isn't walking for 12 weeks, and he is not going to follow. Maybe he will. And it actually, and I will say this, he was a phenomenal patient, and he followed all recommendations and followed all the rules. But, I had to be careful. I meet somebody for the first time, and, I have to kind of make a decision that's going to be for his safety and for maintaining and allowing him to get back to being who he is.
And just to underscore the point, his soft tissues and other kind of HIV status and other things plays into this in deciding on a surface implant versus an intramedullary implant. Yeah,
it does. His soft tissues were actually great. His CD4 count was reasonable, and he had a low viral load. But like I said, he has a home-ish.
Got it.
So in contrast to kind of what they had mentioned, for this one, I'm going to need everything that I can to help reestablish my alignment. And so I actually left the external fixator on for the case. So here you see us looking and locating that comminuted fibula fracture. And so we made an incision, but we were very careful to avoid kind of, disrupting that area of comminution. And so we placed our screws distally. We confirmed on both views. And there you can see above a laminar spreader with a push-pull screw above, which allowed us to dial in our length and our alignment and our rotation for that fibula fracture. Once we did that.
Just to contrast this with the kind of more standard distal third kind of ankle case I showed, fixing the fibula first in this case is part of the indirect reduction techniques to get length back to your tibia, since you don't have a clampable, or easily opened and kind of keyed in distal tibia fracture, correct?
Correct.
Awesome.
People are very finicky about this. I think, the comment we always talk about is you better do this properly. I think it's true, but you do, Milton, I don't know if you agree, you do have a little bit of wiggle room if it's not perfect, right? It's not going to totally hose you, but it's got to be pretty good.
You do if you're going to be long, right? So that is a long plate, and our screws, our 3 proximal screws are as far away from that comminution as we can be. And our distal screws are as far away from that comminution as we can be. So there's a little bit of flexibility, and there's jog and rotation in that thing. So there we are. And so if you look at it, if you critique it, I'd say he's in just a smidge of varus. But he's close, like he's very, very close. And there you can see that long spike extending way, way above. And so from here, we actually converted our external fixator to a femoral distractor on the medial side, because we have reestablished our lateral cortex. So there you can see the distractor in. And someone had mentioned kind of a little bit more of an explanation of the lateral parapatellar approach. And what it is I make an incision just on the midpoint from the midpoint of the lateral aspect of the patella to the midpoint of the lateral aspect of the patellar tendon, take my incision down, and then incise the peritoneum. And then I will elevate, then I'll basically separate the posterior aspect of the patellar tendon from the fat pad. And then I'll elevate the fat pad up with a bovie just off of the anterior aspect of the tibia, just like if you were doing an infrapatellar approach, right? So Mitch does his infrapatellar approach. He makes his midline incision. He sees the fat pad. He elevates the fat pad and finds that spot. I do the exact same thing just from the lateral side of the patella. And I can do that with the leg extended. There's a
I think Kubiak wrote that up initially, if I'm not mistaken, for people who want to read more about it. And then I think, like you said, then Lorich as well, right? Yeah.
Yeah. And then there's a video, if you want to watch, there's a video from Anna Miller and McAndrews and Gardner, I think, from University of Washington. It's WashU at St. Louis, where they actually have a video example of the approach, and it was in JOT. So, and this is the critical point, right? We're finding our end point, and you can see we're aiming towards the center of the talus. We're on a mortise view. We're not on a AP view, and we're in the center down here. There's one step that was left out, but the exchange tube is a tube which allows you to, once you find your start point and you initiate your reaming, you can place a tube where you can go, which goes down the center of the tibia over the wire, and you can take the bent wire out and replace it with a straight wire, and then you can ream all the way down as distal as you need to get to the physeal scar. So
I think a key question with these is, do you routinely ream into that distal segment? Or in this patient, in a similar kind of poor bone quality distal fracture, do you think it's of benefit to not ream and then kind of skewer it with the nail, where you're getting potentially extra fixation of the nail into the unprepared distal segment? Do you buy into that or not really?
I make a decision based on bone quality, because we've all been in those young patients who were like, we're not gonna do that extra reaming, and we start tapping the nail down and it just starts to distract, and we're looking at our clamps like holding on for dear life, and we hate ourselves, and then we back it out, and then we have to either place wires to hold it, or we have to start all over. So I have a low threshold. My reps know to have the exchange tubes in their back pocket, because I'm going to ask for them, and I don't want them leaving the room to go get them.
What do you think, Mitch? If you saw the CT here, pretty porous cancellous bone in this patient, do you think there's benefit to not reaming the distal segment?
I always ream the distal segment.
Okay.
I think it's happened to me too many times, not often, but that time where you spend all this time and then the nail goes in, and it's a little bit unpredictable whether it's going to just skewer the bone or it's going to actually push off the bone. And I also like securing that path, like Milton said, just securing with the end cutting reamer initially and just following it up so the nail goes down that path.
And I put the end cutting reamer in, and then I may go one above. If it's poor bone quality, I may just go to the width of the nail rather than going the full 1.5 millimeters over, rather than I may just go just the width of what the nail is I'm going to put in, just to maintain a little bit extra bone.
So just to be a little bit more clear, or repeat what you said, I'm going to repeat what you said. If you're using a bent wire and you're not used to using bent wires, Milton, just touch your reamer is going to stop at the curve, and so Milton, just put your arrow on like where your reamer is going to stop. It's going to stop there, and you're going to be like, hey, that's not good. I got to ream more, but you're going to start reaming more, but it won't go. It won't go because it's bent. So you're either going to cut the wire, which is like super, super rare, or the two are going to be clamped together. Then you're going to be pulling out. Then this person's going to have a hole in their hand, or you're going to use the like lollipop thing. That's not working.
Or then you're going to put it through the
talus
into the talus.
Right. Okay.
So here's our nail going down, nail going down. And so this is what we talk about, right? So he had that little bit of comminution right across the front. And, you know, I don't need that comminution to be compressed. I just want my nail to have a cortex. I don't want my bolt, my interlock bolt to have a cortex on which to lay. And that's going to provide some stability for me. And so there you can see the most distal one does not need it. And if you look carefully, there's a spike. That spike extends and ends just below there. So it's almost like a little buttress right on that little area that wants to slide and shorten, right? For him to fall into more varus. That piece has to slide down and shorten. And that almost just holds it in place, locks it in position. And so one question that someone had mentioned was on one of Mitch's pictures, he was worried that your medial to lateral interlock was in the syndesmosis. Very important thing to think about on this. I have a better lateral view, but our fibula is behind where my screw is headed. And when I measured, I put my depth gauge out and make sure there's nothing that I'm touching on that far side, right? I take a picture and I feel and I turn my depth gauge around and I sound and I make sure there's no fibula on that side. If there's fibula there, then I'm going to go shorter on that interlock bolt.
Or if you need bone, you may want to go into the fibula, right?
I've done that in a
if you're desperate, yeah.
Yep.
Yeah, if you need that stability, you can go in there.
So this is him at 6 weeks, and this is him at 1 year.
Right kind of stability.
Milton, I would guess there's a lot of people listening who may not have the luxury of having a titanium and a stainless, 6.573 cannulated screw set at their hospital. I think classically people would just have stainless steel versions of those sets. If somebody wants to do this, do you think it's the benefits of having that washer and that augmented fixation outweigh concerns about corrosion using a stainless with a titanium screw here, or do you think that you should avoid doing that?
No, I think you can definitely do it, and I've done it, and I've also, I would generally use stainless for everything. The reps were excited about the concept of having it, and so they had it for me, and I utilized it. But I think that the washer is going to be worth it, and I think a stainless steel one works just fine. You're not going to turn the patient into a battery. The thing to really be careful about this anterior incision, you got to make a bigger incision. You have to spread down the bone. You want to look at the washer going down to the bone. You don't want to wrap up the EHL. You don't want to put it directly on the bundle. So you really have to be very thoughtful when placing the anterior ones.
So probably a good 2.5 to 3 centimeter incision to put that in.
Yep.
Awesome. And I should probably mention, I would guess that that's probably an off-label use of this washer and implant combo that we're
correct. That is an off-label use of that
purposes. Awesome.
So, and I think the biggest thing for me is when I think about these patients and these injuries, and when I stay out of the joint, I want to know, when am I going to let these people weight bear? That is my number one question. And, I think having a nail with multiple interlock screws makes me comfortable and allows me to say, at 6 weeks, I am going to let them be weight bearing as tolerated. They'll start with their cam walker and they'll try to transition out of that over the course of a couple of weeks.
So 6 weeks on that case, to be clear to everyone. Yeah. I think that was a question that came in. Great.
This was another woman with a similar problem, 74-year-old woman presenting with right ankle pain after a fall at home. She has very bad bone.
Don't tell me you're going to nail this case. I'm shaking my head. Go on. I'm freaking out.
She has some lower extremity edema, some lymphedema, and really bad persistent venous stasis changes. So,
Ooh,
you know,
I'm liking the nail.
it's the skin is just, it's not great, right? It's not great skin, and I could put it in an X-Fix till the cows come home and the skin is still going to be terrible. And so for her, similar thought process. I want her to weight bear. I know she probably won't be able to follow instructions. I want to make her as sturdy as possible. So once again, this is extra articular. She does have a fibula fracture, and I think, you know, for me, I kind of I'm breaking my rule. In general, kind of rotational type injuries, long oblique fibula fractures, which kind of fit into that. You know, I think these are injuries where I really, if this was a young person, I would definitely plan on fixing that fibula to help me with lateral column stability, because you can see, right, that's where she wants to go. She wants to fall into valgus. That's where she wants to go. So you can see she has some anterior comminution, and it extends very distal on the medial side. You know, similar to what we mentioned, you know, if we did our measurements, we can fit our oblique screw here. We can fit our medial screw possibly, you know, and that's all you're getting. Your anterior screw may be on some comminution right on this area here. So we may need to think about some other ways in which to provide some stability for her. So same
Maybe
thing, right?
I'll make a quick point that I can picture what this lady's ankle looks like. And, you know, I think one thing, you know, people might think about in this pattern is a tibiotalo-calcaneal fusion nail. But that skin on the bottom of the foot is going to be just as awful as it is around the ankle. So by potentially trying to go antegrade on this through what is presumably going to be pretty decent looking skin around the knee versus going up through an incision on the heel, I think is definitely an advantage.
And I think earlier in practice, I had a nihilism phase where, you know, there was a group of patients who, you know, like you think, I'm going to do a TTC nail for this person, but I'm not going to prepare the joint. I'm just going to place the nail. And, you know, there's too much toggling. There's too much motion. You know, I've had those posterior screws just wiggle their way out of the back of the skin, out of the back of the heel. And so, you know, for me, if I can get, like I said, my 3 interlock screws with a little bit of support, I think I'm going to be much happier and safer with that than I am with an unprepared, you know, tibial calcaneal nail, TCC or TTC nail in those situations. So there I am right in the center of the joint. And, you know, this is more of an AP view. You could say I'm a touch medial with my wire, but you can see that where my wire is heading is to the lateral side. So you always have to remember the bend is heading in one direction, but the wire, where the wire is heading, is where you're going to be reaming. And when I'm using my exchange tube, my goal is to stop my reaming there and make sure my wire ends up on that medial side. So even she gets an exchange tube. So there's my nail going in. And now I'm placing my oblique screw. And you can see that little bit of comminution on that medial side, right at the area where the medial interlock screw would be. And so this is a situation where I think about other ways of augmentation. And so I placed my anterior screw with a washer, once again, to kind of prevent it from falling in. That washer's expanding my surface. And then this is a 1/3 tubular set, 1/3 tubular plate that kind of matches up very well with the interlock screws for this nail. And this is an off-label use of this plate, but it's more of a cortical substitution plate than it is a true kind of, than us actually plating this tibia. And so this plate is super thin, and I can actually place it percutaneously. So there's about a 3 centimeter incision on the medial side, so I can get to that interlock screw and the distal aspect of the plate, and I passed it, and then I will likely have 2 small poke holes for the proximal screws. So there we are. We've gotten my plate in position, and so there's an interlock screw that goes through the plate, through the nail, and so acts as a washer for that medial cortex. And we go above, same thing, acting as a washer for that medial cortex. And this would be a situation where Mitch said, where I probably could have considered, placing these all the way across the fibula. I was less concerned about getting a little bit of purchase because I wanted to get good purchase on that far side. So less concerned about being in the syndesmosis for this patient. And then that plate was bent so that it's around the nail so that I can get a screw around proximally to bring the plate down to bone. And that plate is under contoured, so it gives a little bit of push on that medial side as those screws go down.
You can see even as a measure of poor bone quality, how that plate is intruding into the medial malleolus distally. Yep. Just with that probably 2/7 screw down there.
Exactly. And so there she is. If I'd critique myself and I'd say, I wish I fixed the fibula, or, even if I just gave her a little bit of a varus force to it, and actually put those screws all the way across, but I think that would be a little bit too stiff. So that I definitely critique and say she is in a touch of valgus. And so there she is.
Milton, those screws on the lateral image there, you can see where there's kind of a thickened core diameter through the anterior cortex. Yes. Is that just an option with this particular manufacturer's interlock screws? I haven't seen those before. Yeah, those are a angular stable screw. Her bone in younger patients, I generally will not use them. In her, she's older, she has poorer bone quality, and it has a little sleeve that actually dissolves, that sits right in the center of the nail and makes it provides angular stability, and it's supposed to dissolve after between 6 and 8 weeks, or 6 weeks and like 6 months, so that it doesn't become an ultra stiff implant. It also has the variable angle, the variable pitch, so that it has a little bit more purchase at the cortex. We have some questions coming in just about kind of the plate selection, and I guess my take on this would be probably, if you're interested in using this, a thin, flexible, quarter tubular, third tubular type implant, and then probably just holding these up intraoperatively and seeing if you can get one or both of those interlocks to line up with the third or quarter tubular type implants that you have in your facility. It'd be a little trial and error involved. I'm not aware of anyone making a plate that's kind of designed to have these screws line up with the plate and the nail. No, and
do you drill the hole first, Milton, and then put the screw over the plate? Like you drill the interlock first and then just line up the plate?
No, I line it up. So for this one, I lined it up, got my wire right, and perfect. I did perfect circles just like this.
Oh, you did a superimposed perfect circle. Okay.
Yeah. And I've done this with many different plates. I've done it proximally, I've done it distally, but I can't take credit for this particular plate. My partner, Charles Moon, I call it the Moon technique because he's the guy who did it first. And it really worked well in terms of kind of reestablishing that cortex. I've used other things that didn't fit as well, or where my interlock screws are really off angle and it's a lot harder to get them in. So, you know, I've tried all different plates to try to accomplish this same goal. And oftentimes, you know, you're using a certain, you know, you have to put a 3-5 screw, you know, through that, the interlock hole, because, you know, because the regular interlock bolts do not fit through the plates. And that's the benefit of this plate, was that it fit.
Yeah.
Yeah, that's a good point. To my comment on picking a plate, you know, you may have to use a different size screw to accommodate that as well.
A semi-tubular plate that you flatten can do the job. That actually works very well. It's a stainless steel plate, and it fits a 4-5. It should fit a 5-0 bolt as well. It's a lot. You're sitting on the back table slamming a hammer against the, you know, it's just a lot. There's a lot to it versus just pulling out a plate that fits.
Great. So I think we'll come back to summarize some of these things again at the end, but you know, I think we've seen some creative use of kind of some nail plate constructs, similar to what we might do with challenging proximal third fractures, whether that's to help maintain alignment and add stability, or improve purchase and extreme nailing cases in kind of a cortical substitution, or basically just a large washer type construct. We hopefully made it clear of, you know, when and where fixing the fibula can be helpful for us, and especially thinking about some soft tissue challenges when using an intramedullary implant might be advantageous versus having to lay a larger soft tissue exposure on somebody who's not a great candidate for that. We talked about some advantages with suprapatellar nailing for imaging, and the difference between semi-extended positioning versus the different actual nailing approaches, including extra-articular techniques that Dr. Little talked about, versus making arthrotomies versus a suprapatellar portal. So with that, we will come back to some of those things at the end. If anyone has any other questions, please continue sending them in. Dr. Bernstein's now going to review one of his articles, again, kind of highlighting these distal tibia fractures and the importance of the nail target.
There was at the time we published this, I think it was the same journal, the same publication in JOT. There was an identical paper, and I'll just quickly, again, this is the intro part of our paper. IM nailing of distal tibia fractures have been associated with rates of malalignment ranging from 0 to 50%. Most studies quoting a rate of 5 to 30. So technically, this is not easy to do. You know, just to say you did an IM nail, extreme IM nailing is not really your goal. The goal is really to do this properly. Just a quick review. This is from Paley's deformity book. This looks at the mechanical axis of the tibia and anatomic axis. And in the tibia, as you can see here, they're collinear, and they're basically coincident. So if you take that line, this red line down the tibia, and you take a black line, this case is a joint orientation line, which is a line tangential to the plafond, that angle should be 89 degrees. So that's how you assess coronal alignment in the distal tibia. So that's the lateral distal tibial angle. That's the LDTA. It should be about 89 degrees. So if you want to say, well, how do you assess deformity? Am I doing this properly? Milton mentioned a plain film. If you obtained a plain film or even a fluoro shot, you could theoretically draw a line across your plafond and use the IM nail as a surrogate for the axis of the tibia, and that angle should be about 89 degrees. I just wanted to draw on the screen with a virtual pen there. Okay, so we looked at 130 cases, all were treated with infrapatellar nailing, and we looked at the LDTA, the ADTA. So we looked at the coronal alignment as well as the sagittal alignment of the distal tibia. And we looked at the relationship between the nail target, so that was a line down the nail, and we drove it all the way down through the plafond. And we looked at the distance from the fibula to the distal nail target relative to the width of the ankle. Because the width of the ankle, or the halfway mark, is considered also a joint center point. So where is this relative to the joint center point? Hence why, and that ratio would give us an idea. Same on the lateral x-ray, and then we divide it into quintiles, as Tom and I were discussing earlier. So quickly, 30% of the patients had angular deformity greater than 5 degrees. All were invalgus. All were invalgus. And this table basically shows the coronal malalignment correlated with an aberrant distal nail target. And long story short, if you're aiming medial or far medial, meaning at the edge of the quintile, you're more likely to be malaligned, and more malaligned in valgus. And on the lateral x-ray or on the sagittal plane, if you're aiming your guide wire anterior or far anterior, you're also more likely to be malaligned in the sagittal plane. So it's in a sense a very simple paper, but it just scores everything we just talked about for an hour and 15 minutes. Is secure the distal nail target, because it really will affect the alignment and potentially the stability of your construct. Valgus is the most common deformity after distal tibia shaft fractures, 72% in the literature, 63% in that study. And aiming the distal nail target medial and or anterior is bad. So I would stop before you get to that point. Central or slightly posterolateral protects against malalignment. And I will stop there.
May I make a statement?
Please.
I like a statement.
I think one of the things that I will definitely do very regularly is put blocking pins in for my wire, but may not necessarily leave them in for placing the nail if in that terrible bone where I know it can kind of blow things out. I just want to get my wire to my start point and make sure that I've secured that location, and I don't necessarily need the blocking pins, after the fact.
I think that's an awesome point when you're dealing with poor bone quality and a metaphyseal fracture. After you pass that wire, even with a pretty aggressive bend on the tip of the wire, it often wants to keep following that pathway and can be really hard to redirect it and get it in a better path. So I think, first and foremost, trying to get it right the first time, and not just, okay, we're going to get the guide wire across the fracture site. We're going to really pay attention to where it's going, look at a couple fluoro views in both planes as you're sending it down the first time. But then if it does not behave itself, I think Dr. Little's point is great, to use some sort of blocking screw to help redirect the wire in those cases, because it's going to be a whole lot better to do that on the front end than try to come back and correct that after you've prepared the nail pathway and you've kind of bought a valgus malalignment, 30 minutes later.
Yeah. For proximal, right? For proximal tibia fractures, start point is king. For distal tibia fractures, end point is king, right? So that's that problem with that Erlenmeyer flask kind of shape. So you have to respect it. And I think, that my residents look at me when I'm like, stop, turn around, another view, stop, go again, another view. And they think I'm crazy, but I think that part really, really listening to it and watching it is so critical.
We should make a point with that article, Mitch, you all excluded plate augmented cases, I believe. It's just a point there.
That's a hater move.
Other papers have shown that the semi-extended technique helps improve alignment with distal third fractures, in addition to the proximal third fractures where it's more commonly discussed. And just from a practical standpoint, everything we've talked about tonight to get good imaging and to be able to use these various adjuncts to get your reduction certainly are infinitely easier when the leg is in a semi-extended position versus flexed 75, 80 degrees for an infrapatellar technique. Although Mitch does still like to use infrapatellar sometime, correct?
My default is infrapatellar.
Yeah.
If I'm doing closed nailing and it's imaging is important, or like a distal third, then yes, I will do semi-extended, either suprapatellar or the lateral power patellar, depending on, practically speaking, what my trainees or the people I work with have not seen yet.
So in the kind of classic, more simple distal third cases that you showed, that you're having a low threshold to open those, look at them and clamp them, are you doing the majority of those infrapatellar or semi-extended?
Infrapatellar, but
Okay.
If I'm doing a case like Milton's strategy where I'm going to prepare the proximal tibia and hope closed, then I'll do a semi-extended, prepare the proximal tibia, try to get it closed. And most of the time I do it closed. Obviously I'm showing two cases where I just want to tell you open is okay. And, you make sure your thigh foot axis is okay, length is okay, nail target's okay, and you're good. But I can tell you it's much easier to do an open reduction IM nailing of a fracture that's clampable.
Just a question from the audience along these lines, maybe for Milton. Can the start point for distal fractures be cheated more medial to the lateral tibial spine in order to hit the distal central target point? Does changing your starting point help you hit the distal nail target at all, or are you still using a classic starting point?
I generally will use just the classic starting point, I think, just to stay true to principles. And also with the lateral parapatellar, it tends to kick you just a little bit more lateral for your start point. So you're almost, you just want to be careful because you have to maintain, you have to keep pressures off of the lateral femoral condyle. Even though there's synovium and everything in front of it, it can still do it. So the more medial you move your start point, the more pressure you're going to have when your nail's going in on your distal femur. On your distal femur. So I generally just keep my same start point that I use with all.
Just one more question again about blocking screws. Besides using them to help redirect the path of your reaming rod, are they also useful for you, Mitch, in other steps of the nailing procedure, or helping augment stability? We do that in the distal femur, kind of trap the nail with some blocking screws to prevent any drift, if you will, alignment wise. Do you do that very often?
Yes, if there's enough room. Sometimes, in the tibia, I move to clamping because I find if it's just past the isthmus where it's just opening up, there's not enough room. At least I don't think there's enough room for a blocking screw, but there's plenty of room for malalignment. So then I'll clamp it. But if it's really distal, yeah, I'll push or trap the nail to the nail target so that it increases the stability and it makes sure your nail's protected in the AP and lateral plane. You could do that.
I use them, and I think one something that we kind of all learned in fellowship, and Jeff reminded me of it when Jeff Marisek reminded me of it when he came back here, or when he came to Cedars, just you don't have to use a 4-2 drill bit or a 5-0 bolt for your blocking screw. Utilizing Steinman pins, so a 2.5 millimeter Steinman pin, which is flexible, allows your nail to get around it, or allows your wire to get around it, and replacing that with a 3.5 millimeter cortical screw rather than trying to use something really big and bulky can help you. So, we always talk about blocking screws, but I think most of us place wires, keep the wires throughout the case until the very end, and then exchange those wires or the Steinman pins or the drill bits that we utilize, and exchange those for a screw at the very end, rather than trying to place a screw in the perfect position intraoperatively.
Perfect. Fall there. I raised my hand. Tom, I raised my hand. So
Mitch, you raised your hand, please.
Yeah, I did.
Carry on.
The pitfall there with small wires. If you're close to the reamer will eat your wire. Yep. And it can be very thin. Your heart drops as you take it out, and there's a big chunk. Number two, it's happened to me many times. The reamer takes the drill and shoots it.
Yep.
Okay. So that's also not funny.
It's not funny at all.
Carry on, Tom. Carry on.
That was a very polite Canadian approach. I appreciate it. So thank you guys very much. I think just terrific cases. I hope everyone got a lot out of this. And just to kind of close things up for the evening, hopefully we've made it clear that the distal tibia can be every bit as challenging as the proximal tibia fracture. We've gone over quite a few reduction adjuncts tonight, when and how to do percutaneous techniques, when you might consider opening the fracture, how to clamp things safely, how to use blocking screws, when you might consider using plate augmentation. We talked a lot about pearls to the intramedullary nailing technique, and how critical the distal nail target is, as well as some pros and cons of different semi-extended versus flexed nailing techniques, and some of the things to think about as you move towards nailing more significantly distal fractures, including those that involve the ankle. So again, I'd like to thank you guys for your time and thought and putting this together. And just a reminder to the audience again that you'll be getting a email link to claim CME and do a questionnaire. So please participate with that. And for those that may have missed this live, this will go up on the AO Trauma North America website tomorrow. And if you haven't visited, it's becoming just a tremendous resource. The amount of free educational material on that site is just astounding, just really world-class discussions, videos, and lots of resources. So please check that out if you haven't. And put a plug in for our last fireside of this series next Tuesday, July 20th. I'm sure it's going to be a great discussion on atypical ankle injuries. So with that, I wish everyone good night or good morning, depending on where you're tuning in from. And thanks for your attention and participation.